In our last lesson, we talked about and gave you some examples of different modalities of Doppler ultrasonography, which is really the mainstay of vascular ultrasound. While some people have a working familiarity with color Doppler, or perhaps even power Doppler, spectral Doppler ultrasound is sometimes a bit less familiar. So now that we've got a basic understanding of Doppler modes, the physics behind them, and know how spectral Doppler differs from other duplex ultrasound modalities, let's take a lesson to dive into spectral Doppler in a bit more detail. After we've generated a spectral Doppler waveform, we can assess the waveform both qualitatively and quantitatively. When I say we can assess it qualitatively, what I mean is that we can use its sound, its shape, and its appearance to draw conclusions. Let's start by taking a quick look at some of the ways we can qualitatively assess spectral Doppler waveforms. Qualitative assessment of spectral Doppler can consist of auditory and/or visual assessment. For many providers, a handheld Doppler is used to measure fetal heart tones or listen to blood flow in peripheral arteries. By estimating the fetal heart rate or by assessing the patterns of sounds on a handheld Doppler, we can figure out if there's normal or abnormal processes going on in the patient under our care. On duplex machines that generate a visual waveform plot, we can also use the data displayed to quickly, categorically assess the measured flow's direction, phasicity, resistance pattern, and look for specific morphologies that are present in certain disease processes. The Society for Vascular Medicine and the Society for Vascular Ultrasound put out a new consensus statement in 2020 regarding the descriptions of Doppler waveforms. I'm going to highlight a few key points taken from this statement, but if you're interested in vascular ultrasound or just a POCUS nerd like me, this is a pretty interesting read, and it's freely available online, so I'd encourage you to take a look. Let's walk through each of the 4 consensus categories and discuss qualitative assessment for directionality, phasicity, resistance, and modifying terms. We'll start off with directionality. This is a slide I've shown you previously, with a reminder that flow towards the probe is classified as positive velocity, flow away from the probe as negative velocity, and zero flow plotted along the zero line of the x-axis, the y-axis. So let's take this Doppler waveform and describe the type of flow it is depicting. So for this example, we can see the peak positive velocities repeating at the height of systole, with diastolic valleys between them. However, notice that even in those diastolic valleys, the baseline of our waveform is still well above our zero line. So how could we define the directionality of this flow and relate it to the cardiac cycle? Well, I describe this as continuous forward flow, which does assume we are imaging according to standard conventions where arteries are being assessed with flow towards the probe. And even during diastole, there is movement of blood towards the probe, and that the velocity of that blood sort of picks up or surges during systole, but even when in diastole, continues to flow forward. Now, let's take a look at this waveform. Again, we see the systolic peaks with positive flow, but notice that after the initial flow forward, the curve approaches the zero flow line during diastole. So how would we classify this pattern? I'd say we have systolic forward flow followed by no flow in late diastole. And lastly, let's look at this example. Again, we see the systolic peaks, but you'll also notice that right before each systolic peak, at the very end of diastole, there's a plotting of negative velocity. This is a common pattern we see that we could describe as systolic forward flow, followed by no flow in early diastole and reversal of flow in late diastole. Now, if you just heard those words flow reversal, you may have had the thought of our Doppler measurements that we do for the umbilical artery in pregnancy when we've diagnosed a fetus with fetal growth restriction. We can also look at this pattern in the renal arteries of patients with extremely high vascular resistance due to medical disease of the kidneys or transplant rejection. And while those are specific examples, I would only expect you to be able to describe the flow direction and leave the interpretation to formal scans in most cases. Let's move on to phasicity, which describes the number of phases a waveform has, defined as the number of times the waveform crosses the zero axis. Here are some of the examples of spectral Doppler displays with various phasicities. The top curve shows a steep positive velocity followed by a quick drop and reversal of flow in early diastole with a return to positive flow in mid-diastole and no flow in late diastole. This is a classic triphasic pattern characterized by a waveform that crosses the zero axis twice, resulting in 3 distinct phases of the wave. The second curve is similar in that we have an initially high positive velocity and drop to negative velocity in early diastole, but after that, the curve approaches zero flow. This curve only crosses a zero flow line once, resulting in a biphasic wave. And lastly, we have a couple examples of monophasic waveforms, which show only positive velocities and no reversal of flow. As it does not cross the zero flow line, these are both examples of monophasic waves. Now, it's natural to assume that one of these patterns is normal and that deviation from that is abnormal. But the truth is that all of these waveforms can be found in the vasculature depending on factors such as proximity to the pump or the heart, resistance of the path the blood is taking, and its target arterial beds. And it can also be affected by the compliance of the walls of the vessels themselves. What is normal in one artery may be abnormal in another, and vice versa. Additionally, the body can also change resistance by dilating or constricting arterioles to shunt blood towards and away from different organs. So, for example, if we were to scan my femoral artery, we may note it to have a triphasic waveform, which is normal for that vessel. However, if I performed vigorous exercises of my legs, #leg day, the demand of my muscles would result in dilation of the arterioles that supply these muscles, and it's quite common to see a biphasic pattern develop. And this is because, to a certain extent, the phasicity is determined by the resistance of a vessel, which we'll look at next as our next qualitative assessment. First, however, we should go over what each of these different phasic patterns sound like on our audio assessment. This is especially useful when listening to a handheld Doppler assessment of the distal extremities to determine if there's sufficient blood flow for surgical interventions or when assessing chronic wounds in poor healing and wound care clinic. So here's an example of a monophasic waveform, and I'll give you the caveat that this isn't the best example of it, but what I want you to try to hear is that the blood seems to, or the phase seems to be moving in one direction, almost continuously throughout the cycle. So it should be sort of like a shoo, 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 or blowing type of sounds. Here's what it sounds like. Now, let's turn our attention to a biphasic form. So with this one, we should hear 2 distinct phases. And lastly, hopefully you can predict what this one's going to sound like. This is our triphasic waveform. So if you need to listen to those a few times, go ahead and do so, but being able to identify especially a triphasic form from a biphasic or monophasic, it can be really helpful when we're trying to determine if someone has an arterial stenosis or peripheral arterial disease. Next, let's turn to a quick comparison of resistance patterns. For our sake, I'm going to show you the extremes on either end of the spectrum. But of course, there are also some variations in intermediates that are somewhere between these two poles. But for our sake, what I want you to know is that high resistance patterns typically exhibit sharp, almost peaked systolic flows with sharp, brisk strokes, with either flow reversal or limited flow in diastole. This is the classic pattern that's seen at the end of distal ends of long arteries that supply the extremities. On the other end of the spectrum, we have low resistance patterns. These are seen in arteries that supply low pressure systems like the brain, the renal and hepatic arteries, and the uterine artery during pregnancy. Because these arteries supply vital organs, they require continuous blood flow, and thus we see a more gradual downstroke in early diastole, with ongoing forward flow exhibited throughout the whole cardiac cycle. Lastly, we're going to look at some patterns that can be seen to the trained eye when assessing spectral Doppler waveforms. And the guiding organizations refer to these as modifier terms or modifying morphologies. The first modifying term we see is called spectral broadening. And what this refers to is a widening of the spectral band, resulting in a wider, fuzzier display of our waveform across the time. I alluded to this earlier when I explained why we don't get just one single line on our Doppler waveform, but instead this fuzzy plot of various frequencies. When flow is disrupted for a variety of reasons, the velocities are even more broadly distributed. And this results in the spectral waveform widening, sometimes to the point of completely filling in the space under the curve with signals that represent flow at all different speeds. I hope that you can see that in the very top tracing, we see that there's almost one distinct line. We still have a little bit of fuzziness, but you can see these little windows underneath the peaks in systole, and even in the diastolic peaks that are below the line, you see there's an area where there's no fuzziness, there's no pixels, there's no white, it's all black. What happens when flow starts to be disrupted is that fills in. So as we look at the second and the third images, we see that space sort of fills in to become completely white. The more disrupted the flow becomes, the more likely it is that we'll lose that little spectral window as it fills in with Doppler signal. And so the takeaway here is that this can represent less laminar, more turbulent flow patterns, which may or may not be normal depending on where exactly in the body you're assessing it. The next change we'll refer to is sometimes called a prolonged upstroke or pulsus tardus. What this refers to is a pattern that shows an abnormally gradual slope or a prolonged time to reach the peak systolic velocity. Whereas we typically expect really brisk, rapid upstrokes in systole, a prolongation can signify an upstream narrowing or obstruction. Different vessels have different consensus cutoff values if you were to measure this, but for our sake, just recognizing that the upstroke is sort of broad, it looks more like a delta wave with a WPW patient, that's really all I would expect you to know. And that's just knowing that can represent a more proximal obstruction is sufficient for our purposes. And then our last qualitative assessment modifier is actually a combination of the two that we've already seen, both spectral broadening and a prolonged upstroke together. And when seen in combination, we call this dampening. For historical purposes, this is also sometimes referred to as pulsus parvis et tardus, which you probably learned in medical school as being a physical exam finding of aortic stenosis. And the logic for this holds up here as well, as significantly obstructed flow, such as that seen in severe aortic stenosis and near occlusion of vessels that greatly reduce the magnitude of flow, this results not only in a prolonged upstroke and spectral broadening, but also results in a shorter or weaker velocity than typically seen in the same vessel of a healthy patient. So that Latin phrase parvis et tardus means weak and late, which certainly describes what we see in this pattern. Now, I know that was a lot of information to digest. And while I do want to show you how quantitative assessment can help us further discern the degree of disease exhibited, for most POCUS purposes, I would not utilize quantitative data. What I want each of you to be able to do is recognize that qualitative findings we've gone over thus far, and then have a working familiarity of the measurements seen on the next slide, which are often referenced in literature or when spectral Doppler is being utilized for studies, or sometimes even on the reports of exams we order for patients in the clinic and the hospital. Quantitative assessment of spectral Doppler involves recognizing a few key points, namely our peak systolic velocity, or S, and our end diastolic velocity, or D. The time it takes for the systolic upstroke to reach peak systolic velocity is called the acceleration time, and if stretched out or prolonged, this is a way to quantify our prolonged upstroke. Using the peak systolic velocities and end diastolic velocities, we can calculate a number of indices and ratios that sometimes give us clinical information. We can also sum up the area underneath our curve for one cardiac cycle, and this is referred to as the time velocity integral, a value in length, usually centimeters, that refers to the distance of displacement of blood for one cycle. We can then take that product of the time velocity integral and a cross-sectional area, say of the aortic valve, and this would calculate a volume for us. So if we're using our example of the aortic valve and we take the TBI and multiply it by the cross-section of the valve, that would actually give us a stroke volume, which can then be multiplied by our heart rate to give us the value of cardiac output. Now, do I expect you to be able to calculate these or even memorize the formulas? No, but maybe they give you an idea of how advanced scanning can utilize the data found in Spectral Doppler to help us answer clinical questions about our patients using non-invasive approaches. And that's really all I want you to know about Spectral Doppler. And we'll get some examples and ways to practice this with our Vexus protocol, which will be coming up in our next lecture. My final reminder is that all of this data, from qualitative to quantitative, must be related to the specific vessel that one is imaging. This level of precision and expertise in interpretation doesn't really lend itself to the screening nature of POCUS exams. But there may be certain practice environments, such as if you work in a wound care clinic or if you plan to do more advanced echoes in your office in the future, that might persuade you to learn these skills and practice them. Regardless, I hope you found this an interesting exploration of a relatively uncommon use of point-of-care ultrasound.